Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Today, we are here in Rochester, New York, live with CEI, the New York State Continuing Education Initiative. And we're speaking with leading physicians who have been on the front lines of translating rapidly evolving science into practice and education for all of New York. From our roots in CEI of advocating for clinical education in the very early days of HIV treatment, to now our modern approaches in training on the syndemic, such as drug user health, harm reduction, Hep C, STIs, we're exploring how the science around these syndemics has transformed and what that means for continuing education around the state. Let me take a moment to introduce our incredible panel of experts today. We have Dr. Tony Urbina, who is an infectious disease physician and the medical director for the Mount Sinai Institute for Advanced Medicine in New York City and specializes in HIV care prevention and treatment. Dr. Daniela DeMarco is an infectious disease physician and has a master's in public health. She is currently an assistant professor of medicine at the University of Rochester, specializing in HIV, sexual health, and STIs. Dr. Linda Wah is a general internist and an addiction medicine specialist and serves as the medical director for the Hepatitis C and Drug User Health Center of Excellence at Mount Sinai Medical Center in New York City. Dr. Stephen Feib is an infectious disease physician at the University of Rochester and has spent years as the Hep C medical director at a local federally qualified health clinic. Dr. Timothy Dye leads our CEI Research Center. He is a medical anthropologist and social epidemiologist who specializes in biomedical informatics and data science, particularly at the intersection of science and health. So let's start with talking about the science. Clinical guidelines, really in each of your areas of expertise, has changed pretty dramatically and sometimes even overnight. So I'd just like to hear about the evolution of both the science and education. First, I'll start with you, Dr. Urbina. So in terms of HIV, how have really the landmark shifts of U equals U and really the new long-acting injectable HIV treatments really changed the landscape for your patients and also for your colleagues of clinicians and how we educate clinicians throughout the state?
Yeah, sure. Thank you, Renata. So I think U equals U has been such a pivotal kind of phenomenon, just helping our patients reduce stigma. I think it's really in line with our rapid starts and getting a patient living with HIV to undetectable, just unequivocally undetectable. You cannot safely transmit HIV infection. So I think that's really galvanized just our HIV treatment and just our rapid start initiatives. With regard to novel agents, I'm most excited about these long-acting injectables, in particular in patients that are viremic.
Right.
So we know that there are indications really as a switch for patients that are suppressed, but now there's been published reports about patients that have viremia and start them on these long-actings, and then they can get to U equals U. In addition to that, I think there's newer oral agents. I think the big kind of issue with HIV is patients are living with HIV into their 70s, 80s, and 90s and beyond. I think my oldest patient's fine. So I think with these newer agents, we're starting to see drugs that maybe have less toxicity, less issues with weight gain, metabolic disorders. So I think these two drug combinations that are going to be free of certain antivirals are really interesting. And then lastly, I think just newer ways to dose the medication. So not so much daily, but we have weekly and maybe even monthly options that would be available for patients. All of this really involves, I think, CEI's input in terms of training physicians, not just about the science, but about how to implement.
Yeah, absolutely. It sounds like really the landscape can really empower our patients. And hopefully we're educating our clinicians really to do that. It's stigmatizing U equals U it's so important, I think, empowering our patients. But then just the flexibility in order to have a patient-centered approach, almost like a menu of options and what works for these patients, I think is going to be so, exciting for the individual relationship between the patient and the clinician and how they talk about that. So I think it'll be interesting if really how that comes out, and CI will take a lead role in kind of leading that really wonderful patient-centered therapeutic relationship.
I couldn't agree with you more.
Yeah, and tell just a little bit more. I know there's currently an injectable prep, so HIV prevention, and soon there's going to be an FDA approved once every 6-month injectable prep formulation, lenacapavir. I'm just curious your thoughts about one, how this could change the landscape and the epidemic, and also how we can help clinicians implement this for their patients.
Yeah. I think just like you mentioned, I think the more options we have for patients, the more we can reach like populations that may be more impacted by HIV, maybe that are not as trusting of like medical establishments and things like that, by providing different routes. So I'm very excited about lenacapavir. It's going to be 2 subcutaneous injections every 6 months. When they first start, I'm going to get an injection plus 2 tablets. Now on the second day, 2 tablets. And then their next injection is until 6 months. So I'm thinking that might appeal to like women, maybe people that use drugs, just different types of populations where maybe an alternative to having to take something every day is not as attractive. So I'm really excited that I think with these novel technologies that we may be able to target different groups and then really get to our goal of like ending the epidemic.
Yeah, totally agree. And I think what's important is when we have something that's like every 6 months and an injectable, potentially clinicians can be thinking about how they can like partner with community-based organizations where traditional populations have a lot harder time. It's very hard to get into our healthcare system, right? But populations that maybe are accessing, things outside the healthcare system that are willing to partner, you may be able to sort of take those very novel interventions and bring them sort of outside sometimes the traditional healthcare system. So
yeah, I agree with that. Yeah. And I also think CEI has helped because currently we have this long-acting intramuscular PrEP agent, long-acting hepatitis. I think CEI is really helpful in helping institutions and clinics and individual providers kind of implement it. So I think that's the biggest challenge. Like the science is there and these medications work, but how long do you access the medications? How long do you get it authorized? All of those steps and insurances in our kind of complicated health insurance system, I think it helps to have kind of guidance about how one can roll it out successfully.
Yeah, absolutely. So we will look forward to CI doing, helping that as the new medications get approved. Thank you.
Do you think the long-acting lenacapavir for PrEP will be available in primary care offices or outside of specialty?
Right. I think that's a super good question. I think there needs to be an infrastructure in place to kind of implement that. I think it relies heavily on nursing, just to perform these injections. Not that clinicians couldn't do it, but so I think infrastructure is really important. I do think that the medication will be able to be accessed via these pharmacy benefits. So there could be alternatives for accessing the medications, but I do think that we need to have a robust injection practice in order to do it successfully. So maybe we'll have designated kind of centers of excellence for this, but I'm hopefully that more people kind of buy in and want to do it.
Yeah. And I think, what's important is making sure we're educating people about the science, but then also making sure we also have trainings about exactly what you're saying. How do you implement this in things like primary care? How do you make this low barrier, et cetera? So moving on to kind of STI prevention, I wanted to ask Dr. DeMarco a question. So we are in an era where we finally have one of the first biomedical STI prevention, meaning a medication to prevent sexually transmitted infections called DoxyPEP. As the lead author, actually of the New York State DoxyPEP guidelines, you've really been on the forefront of shaping that evolution of STI prevention. So, how do you think this strategy has been incorporated by physicians? Are they taking it up? How do you think the community of patients have responded to this really new, innovative approach that we haven't had for forever?
Yeah, it's a great question. I think we're seeing a little bit of what we saw when oral PrEP was first rolled out several years ago, where there is quite a bit of consumer or patient awareness, and people are looking for the medication. They're looking for that prevention option. It's not going to solve, the epidemic of STIs in New York State or nationally, but it's absolutely something that has been shown in several trials to be highly effective in some populations at elevated potential for STI exposure. It's a great option for some folks. We see hesitancy and, how do we approach that with clinicians? I think clinicians look for data. So they really want to see science guiding practice. So what's the data in terms of patient or consumer needs, wants, acceptability? That really looks favorable. What's the science? What's been published in terms of not just efficacy, but effectiveness. And so we've seen some pretty favorable publications coming out from that respect as well. As we get that information out there and as we give providers tools and training to sort of expand or even just increase how they're doing this in their practice, we're seeing uptake expand as well. And so we have a couple of quick reference tools that we put out there. New York State guidelines came out over 6 months before CDC guidelines. So we hope that providers out there in New York are, using the guidelines to help them implement this into their practice. A lot of folks are just looking not just in primary care, but even in STI clinics, Planned Parenthood, in various places. How can you incorporate this component of the sexual health toolbox? It really also starts with just taking a sexual history as part of routine visits. And so, you won't know it's an option for your patient unless you launch in with just, some basic questions. So I think there's a lot of opportunities to expand implementation, to expand uptake. The patient awareness is out there. It's not as high as it has been for PrEP, HIV PrEP. And so there's still quite a bit of work to do on the patient education side as well as the clinician side.
Yeah, absolutely. And I like what you said. I think, CEI taken, obviously we have done, historically really, cared about STI prevention and treatment. But I think what's been really nice is that you all have also taken a pretty sexual health approach to educating clinicians. If you, I think maybe if we, I love that you have, how to take a sexual history as part of the, CEI platforms. And I think the more that we train all physicians to consider sexual health as part of regular health, the more likely we are going to be able to implement and use these really wonderful biomedical interventions. So I'm just, how has the receipt been sort of really trying to get clinicians to open that conversation up? And are people interested in this topic?
Yeah, absolutely. Clinicians out there want to do what's best for their patients, and they are really constrained by time.
Yeah.
And so, everybody's doing the best they can. And when you think about, as a sexual history, I have to spend 15 minutes talking about all these different things. And what about the privacy of it? And there's a lot of things that could pull you back a little. But I think clinicians will find as they start to do it, that patients do actually want to talk about things. It does take a little bit of trust building. So maybe it's just one question at the first visit, and as you build that relationship, you start adding in a little bit more. But it really is meant to be a conversation and not sort of several questions in a row without any give and take. And so as you open that conversation, you get to know more. And it's not just about STIs. Maybe it's also about pregnancy planning, be it prevention or fertility questions. It's about partners. It's about safety in terms of, maybe you do have to ask some folks about trafficking and things like that. And, we also ask about sexual function and pleasure. And there's just a lot that goes into it, but you don't necessarily need to feel like you're asking that all at once, and that, take it in stride as you get the science from the patient through the conversation.
Yeah, I think that's important. Just, I always laugh, like making it, are you having sex is a vital sign,
Daniela, I often get asked this question, so I'm curious to see your thoughts. Just for doxy-PEP vaginal exposure, how do you counsel your patients or other clinicians about that?
Yeah, that's a tough one because the data that we have so far hasn't been favorable in terms of efficacy. There was a trial that was conducted in Kenya with cisgender women who were on HIV PrEP, and it didn't show benefits in STI reduction, but there appeared to have been some adherence issues in a small sample there. But There's a couple other studies that are ongoing. There's one pharmacokinetic study, but the other, animal model study in the cats with like a doxycycline insert looked favorable. But the other sort of human models that they've looked at so far, there's sort of mixed results. And so I don't know what we're going to end up seeing. And we don't have sort of a really great planned randomized trial for this. And folks assigned female at birth, they deserve great data and great trials too. But I think there's an opportunity, depending on the person's potential for STI exposure, that you might sort of counsel them through, this is what we know, and it's not a lot. And, this is what we know about your chance of getting an STI over the next 6 months. So let's try to balance those two individually and see if we can come up with the answer.
I like that. So I have a shared decision, right? Based on like the best of them.
Yeah.
Thanks.
And keeping them in care. So, what's interesting is a lot of what we're talking about, we don't traditionally think of as harm reduction, right? But we're really talking about how to reduce harm when people are engaging in sexual activity. And, but traditionally we also often think of harm reduction in the context of drug user health. And so I'd like to really turn to Dr. Wong and ask you, as the concept of harm reduction, and for specifically like harm reduction around drug use and substance use disorder, has becoming the medical standard. How does your framing of substance use disorder and stigma and care delivery in a primary care setting, how has that evolved? And how do you talk to clinicians about caring for patients who have, multiple risks and how to reduce harm?
Yeah, I think it's opened the door. And so like Tony was saying, now we have a menu of options and we have the ability to counsel people on many different pathways that we could take. Historically, I think we've only, we've been trained that abstinence is sort of the gold standard way of dealing with a substance use disorder. And with harm reduction, I think it's really opened the doors to clinicians and patients and family members considering other options that may work best for that individual in front of them. Not everyone is going to want to pursue abstinence. And now we don't have to say, well, sorry, we don't have any other options for you. We can say, okay, well, let's talk about all the other ways that we can keep you safe and healthy. And I think harm reduction really gets at that humanness of everything, of healthcare, that I think sometimes is missing when we focus so much on the biotherapeutics. And I think it's really important now more than ever for not just CEI, but all providers and all health agencies to really double down on the messaging that harm reduction is safe, it's effective, it has decades of evidence backed by science to show that it helps reduce things like HIV transmission, hepatitis C transmission. It reduces morbidity and mortality related to opioid overdose and other complications related to opioid use. And I'm really fearful because we're in a landscape now where harm reduction is under attack nationally, regionally, and locally. From San Francisco to New York City, what we're seeing are legislations that do not protect harm reduction. We're seeing funding cuts across the board, which I think everyone in this room has experienced. And so I think because of harm reduction being under attack, I think we as an organization, we as providers in this healthcare system really need to double down on our messaging. We need to say, look, harm reduction saves lives. These are the facts, and address the myths that go along with harm reduction, which have a lot to do with stigma, right? Stigma and lack of understanding and education. And we also need to be clear what providers need, because the clinical infrastructure, as Tony was pointing out, doesn't necessarily exist the same way in many different settings. And so we may need to pivot and talk about harm reduction and harm reduction messaging in different ways and different practices so it better serves the need, not just of the provider population, but also the patient population.
Yeah, I totally agree. And I think what I like about CDI is there's a lot of conversation on anti-stigma and actually giving lectures and trainings on how to, trauma-informed care and anti-stigma around many things, including drug user health. But I think we also have a lot of actually skill-based trainings on how to bring harm reduction into your clinical room with the patient. And what I think is also kind of like when we talk with all of us, it's also all about keeping the person engaged in care, right? We know we can save lives if we're reducing harm. People, gain trust with their clinicians. We have patient-centered approaches where the clinician and the patient are kind of, having a conversation about what's best for them to, one, stay alive, and two, to stay alive healthier. So I think that's really great. And, and I love that. But I'm yet to keep going about that to keep our loved ones safe. I will say and also in the last decade, we had a really effective treatment for opioid use disorder. And obviously we are in an opioid epidemic, and that is buprenorphine. And I think one of the things that was done federally was to reduce the DEA did take away the waiver in order to prescribe buprenorphine, right? So theoretically, we should be having a lot more prescribing. One, I'm curious if I think that the communities have picked up buprenorphine treatment in sort of outside of specialty care, meaning in primary care and other non-traditional non-specialty care places or non-traditional healthcare settings, and also how CEI and hub training can sort of more effectively get people to also be treating and discussing harm reduction sort of simultaneously.
Yeah. I'm aware of emerging data that do suggest that since the federal deregulation, the elimination of the X waiver, that there may be more prescribers, but I don't think we're seeing enough. And I don't think we're seeing enough prescribing from the existing prescribers or even the new pool of prescribers. And I think eliminating the waiver was a necessary step, but it's only one part of a larger multi-pronged effort to sort of encourage provider uptake, as with anything. Certainly it was a barrier, and we're so happy the barrier is gone, but I think stigma remains entrenched. Lack of provider support remains a challenge. I love that Tony was talking about long-acting injectables, because I do think one of the things we're trying to do with our center is really talk about rapid buprenorphine initiation via long-acting injectable, which is available in weekly and monthly formulations. And I think has a lot of benefits. You no longer have to go to the pharmacy on a monthly basis or a bi-weekly basis. You don't have to deal with the highs and lows of the medication peaking and then dropping very quickly. So I think that's sort of the next move, is thinking about what are the more innovative low barrier models to treatment that we can teach more people about, and also teach them how to implement in various clinical settings that may not have all the resources. I agree to your question earlier, infrastructure is a huge issue, and buy and bill models may not be available for all the clinics, even though buy and bill, I think, is a better way of implementing these injectables. So you may have to use particularly pharmacy benefits, but we need to be able to pivot easily to talk about how to do this implementation in various settings. Yeah. And also, I think we probably need to hear more from the providers and collect more data. I don't know that I have a good sense in New York State. What does buprenorphine prescribing look like? Yeah. We need to know who's prescribing, who's not prescribing, how is it happening? Because I would love to expand it for all frontline provider settings, primary care, FQHCs, you name it.
Yeah.
I was going to say, wouldn't it be great if somebody could get their sexual health care, their buprenorphine, their Hep C treatment, and their HIV PrEP all in the same place? And, it makes sense, and it's such a great idea, but in so few places, and in large part because of how the funding streams are, and the infrastructure, can you actually do all those things together?
Yeah. Yeah. And I think as we, think about it, do this, we really do need to take a patient-centered syndemic approach and test and treat. And all of these settings are important. And speaking of test and treat, I'm going to talk to Dr. Fine about hepatitis C, which we are, currently, really, we went through such a long, difficult regimens, right? In the early stage of Hep C. We really had, one of the biggest scientific advancements of our time is that we have highly curative therapies, right? In under a decade for Hep C. In a lot of ways, a test and treat model. So, how did this really huge scientific shift change your urgency and optimism when delivering clinical education? And, do you feel like that we've gotten there in terms of, I know, we've done really well in New York compared to a lot of other states, but how have we gotten there in terms of test and treat, curing people, implementing this? And what can we do better?
Yeah, that's great. Those are really great and important questions. Since I have been treating hepatitis C, there's been such a dramatic shift in what we used to do. For people who don't remember, if we required specialized patient education to teach them how to give themselves injections multiple times a week, that basically made them feel like they had the flu for at least a year, if not more. And it was really a very specialized endeavor. We had to select our patients really carefully, who would benefit the most from treatment. who was likely to complete the treatment, because we didn't want to put people through 6 months of basically hell in order to only have them quit and not be able to limit. Whereas now we have medications where you can take 1, maybe 2 or 3 pills a day for 8 to 12 weeks and be completely cured of hepatitis C. So it's been a huge shift in the paradigm of who ought to be tested and who ought to be treated, from very careful patient selection and specialists doing all the work. So we should try to educate people, find your hepatitis C patients and send them to the specialty clinic. Of course, many of them would get lost along the way and not end up getting people.
Yeah.
So now we've kind of shifted to, if we can find these patients, you can treat them. And it's pretty simple, actually. And I've done podcasts in the past, and there's been quite a few guidelines set up for a simplified treatment of hepatitis C. So now the whole education is going toward, making clinicians realize that it's not really intimidating anymore. You can do it yourself with the labs that you've already drawn, patients that are in your office at that moment, not getting lost by giving referral.
Yeah.
So we have, trying to get the word out that these new guidelines exist, and all you really need is to see the patient, evaluate whether or not they have some other condition that would make things more complicated, and then for the most part, start them on medication.
Yeah.
And follow up is very simple as well.
Yeah. And I think what, CF is really tried to empower people, clinicians, primary care physicians, to really realize that there are so few side effects. There's so much less than even statins that we use so often, and that this is, and so few tests that you have to get, even while people are on these medications, that really, in an epidemic, which we have in a Hep C epidemic, where you can cure someone, this is really the time to, again, implement this kind of quick test and treat type of thing. And I think what's also very cool is it's curable. Very few things you can cure in medicine. So this is very exciting for both the patient and I think, and for the clinician.
The biggest complaint I see with patients who are on hepatitis C treatment is, gee, you must have given me the wrong pill because I don't feel anything. It's not giving me any side effects. And the second biggest complaint is, aren't you going to test me more and draw blood and all those things?
Right.
Whereas we really don't have to do very much of that at all.
Yeah, no, it's great. And I think we can both attest, people with people who are very sort of, who may be using drugs or currently, homeless, even street homeless. These medications are really good. And even missing a few doses, cure rates are near 100%. And we can get most people through it and cure, which is an extremely exciting thing, not only for the patient's health outcomes, but really for public health in general, the idea of stopping epidemic.
And circling back to the syndemics, there are still quite a few challenges. We have this great medicine, but we can't roll it out equitably because there are huge challenges and barriers with adherence in folks who are unhoused and they're just not able to secure and retain their medication and finish that course. So, how do we tie in some of these other services that would really allow us to treat more people effectively for Hep C? I think these are sort of the real world questions folks are.
Right. So again, we got to teach people the science, but we also know that we need to teach people literally the logistics of implementation and the other services that people can use, like peers or care coordinators that can help really successfully get people through these really wonderful biomedical interventions. So I think we've all talked to these are like kind of extremely innovative science changes that are helping our patients and our communities and our colleagues. And I just wanted to briefly turn over to a little bit of how we are educating, right? Because I think, old school, we did a lot of in-person education and that's we still do that at conferences. And I think that's extremely helpful. I think, but we also are in a digital world. So I want to turn to Dr. Dye and ask you a little bit about how we deliver this new innovative science through CEI, through education. So whether it's like virtual platforms or tailor targeted trainings, from your vantage point, What's been key in keeping clinical education both accessible and impactful, really in a digital age? Where are we now, and where can we go as we try to reach more clinicians and healthcare systems in order really to get this new information out there in a digital age?
Well, what's really fascinating is just listening to this conversation for the last half an hour. Probably 20 to 30 issues have arisen that related to science, the clinical implications of science, equity, policy, implementation, how things, are delivered, how you reach, and how a clinician can know all of that in an atmosphere of constant bombardment with all kinds of information, including a lot of misinformation or poorly designed information. It's impossible. Medical school is not going to do it anymore in terms of preparing you to know all of these things that you really have to be connected to. So the first thing that's required that CEI delivers, and other providers too, is having a sense of vetted, curated information. So information that's produced by experts, that's vetted and curated, placed where people can access it. So you're not just getting information from searching something on the internet without that kind of authoritative sort of connection. So just having it vetted and having it curated in one spot is helpful just in and of itself. Another thing that's very important that we have to pay attention to is how people learn. So I never really use the term education in my field. I'm a professor. I just see it as partnering and learning, sharing information, learning skills. And all of that is done in a particular way with adults. I think it's probably done in a particular way with children too, that's not too different from adults, but we act like they're really different. But adults learn because they need to know something. They need to know something in the moment. They have a new thing that they want to learn. There's a new treatment, or they're vexed by getting access to services for their patients. And they don't understand why it's going on. So they have a particular thing that they want to know. So how to deliver that information is not by taking a 3-credit class on health policy. It's, you need to know kind of in the next 5 minutes, what chunks of information do you need to know to make this decision or to add to your quicker skills so that you can do that. So part of adult learning is delivering information as you need it, when you need it, how you need it, and what you need. So making sure that information is delivered in a way that's in chunks. I don't know about you, but when I go to YouTube, I always look for videos that are under 5 minutes, 3 minutes. I want to learn something. I just want that. I don't want a whole lecture on something. I want that. So CEI has all kinds of ways of delivering this information, but particularly where you can go into this rich catalog of information and find what you're looking for. I think the last thing that's really important that we have to take into account, again, I think this is great for all learners, is tailoring it to the way you learn. So even at this table, with people sitting around this table, everybody learns differently. Some of us like to be with other people. Some of us want to be online. Some of us are going to be on our phone in the middle of the night. Some people just want to call, ask questions. So all of those are valid ways of learning and sharing information. And we always have to make sure that we're delivering information that's accessible to all of those learners. We're going to miss a chunk of learners if we don't do that right.
Yeah.
So making sure that we deliver information in as many ways as there are learners, having it be tailored to what people want to know, making sure it's curated, making sure the systems all work so you can log in and get the information, things don't crash. So all of that has to be paid attention to in this day that we're constantly bombarded with all kinds of information, misinformation. Even if you live in a different state other than New York, the information you have access to is already different.
Yeah.
So, it's a real jungle in terms of trying to sift through all of this, and having a curated spot with accessible information the way you want to learn really helps you learn.
Yeah, and I think that's very, all great. And I think that's what I think is, nice of CI. We sort of have different ways in which we do that, right? Like you said, we have the online course that if you want to like have popcorn at midnight and learn something, we have that, but it's a vetted expert that is, from New York State, and that's giving you not only the science, but potential implementation and even the policy that goes along with New York State, right? Because policy changes state to state. We have live online courses where you can interact. And I know that the research center has really worked hard at making those, a lot more interactive, right? Having questions out there, whatever. But we also know that humans like to be in contact too, and like keeping those conferences going where people can kind of come together and chat about both science, implementation, and policy are really good. And I think more and more, like you said, doing smaller snippets for people with, less time, et cetera, we'll see evolve. I think one of the things you mentioned that I wanted to ask Dr. DeMarco about is calling in real time. I know that the CEI line, actually, particularly for the sexual health part of our CEI program, has been pretty well utilized recently. And I just wanted to let everyone know that actually we have a CEI line that you can call in for sexual health questions, drug user health questions, buprenorphine, Hep C, and STIs. And I know given rising rates of syphilis, we've seen some of that. So I'm just curious about the CEI line and your experience with it.
Yeah, I think the CEI line is probably one of the most satisfying pieces of our current program, just because the volume has expanded so much and allowed us to really immediately, sort of real time, respond to the changing epidemic of syphilis and really our local and regional New York State epidemiology. So with many more cases or many more diagnoses of syphilis and congenital syphilis, we've been able to sort of become that go-to resource for providers who are just looking to figure out, do I need to do an LP for neurosyphilis, or, what's the right screening recommendation for these pregnant folks, just when it comes down to syphilis, and how do I do that in my practice, or just something as simple as one of these lab results. So it's allowed us to really develop relationships with providers across New York, and even relationships with laboratories, hospitals, different types of centers, to really improve the management of pregnant folks with syphilis, the management of neonates with congenital syphilis, but really just looking at syphilis prevention and treatment in general across New York. And we have, for the first time in many years now, seen a change in the epidemiology of early cases of syphilis in New York State. And though I can't take credit for all of that through CEI, I'd like to think that our sort of provider education initiative throughout New York has still helped clinicians provide or change the way they provide services when it comes to STIs.
Yeah, I think that's really, really amazing. I'm so glad that is available to our New York State clinicians. I also think to sort of wrap up, I really think it's important, like, as physicians or prescribers in general are listening in, if you're taking care of a pregnant person who may be at risk for syphilis, they may also be also using drugs or have substance use, or maybe should be tested for Hep C. Or I really think the idea is, what is wonderful about CEI is, like, we really are taking a syndemic approach that is keeping, or really, honoring and keeping alive and healthy populations that are often left out of the healthcare system. And I think that all of our courses and all of our conferences and a lot of our live interaction stuff can really help take care of not just one patient, really, one thing for one patient, but perhaps many things for one patient. And all of these trainings are extremely important, as we start to realize that primary care is multifaceted. So I thank you all for being here, and thanks for everyone who's listening. Thanks for all your expertise and for your help.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.